we're going to go through our angina meds, and then we'll probably start our next lecture after, because we've seen a lot of these meds again, but now we're going to talk about using them in your patients who have angina. So we'll do that when it's break time. If somebody can let me know, well, I'll have my clock so I can remember every minute. There was something else that I wanted to say. I'll probably think of it during break. Did I owe you guys anything else? The reviews are up. So when we go through the heme lecture, it's kind of long. I was able to declutter the slides, but not necessarily shorten the slides, and there's still a lot of stuff on the slides. But I did post the review for that also. So you have for every lecture, you have the review for them posted right under it. So if you want to go through the paper, like print out the paper and go through it whenever we're doing the heme lecture, it probably would be helpful for you to see it that way. All right. Here are your ELOs listed here. Pathophys, y'all are kind of getting a lot of that. We already went over a lot of that, but this is more so like definitions and terminology kind of wise. So when we're talking about ischemic heart disease, this is essentially looking at, like, again, that imbalance that we were talking about between the supply and the demand. So what my myocardial is saying that it needs for that oxygen is my ability to supply it. So our different types that we have will vary with how your patient is going to present. A lot of times we catch things before they're bad, and sometimes you have silent forms where we don't catch them. Sometimes they can be more detrimental depending on what type of event it is that they have. So ischemic heart disease, just think of it as like the big umbrella. And then you'll see a lot of these patients will end up like they have coronary artery disease, things that are actually blocking the artery from being able for us to get that blood to where it needs it to go. And therefore you'll see a lot of these symptoms that we're going to talk about. You have stable, unstable, silent, and vasospastic, which you'll hear a lot called Prince-Metal ovarian. And so looking at this, I just have this here for you to reference it because when we talk about the indications for some of our meds, you'll see where it says like specifically don't use it here, or it's okay for you to use it here. So our stable is essentially like they just feel, a lot of people will say I can feel like an elephant is on my chest, like squeezing, very hard for them to breathe, they'll have a lot of pain. You're unstable, this is more so where like it changes depending on the intensity of what they're doing. So like if I were exercising and then all of a sudden I start to feel this pain, and then over time it progressively can get worse. You're silent, these patients are asymptomatic, these are the ones who are going to have more issues because we don't even know that it's going on sometimes, or they'll be coming in for like a checkup and then you will discover like, hey, you have some blockage or there's something going on under here, even though they haven't actually experienced anything. And then your vasospastic, this is just like some of your patients who will have just random spasms that occur, and then most of the time they can resolve themselves. So typically what we see is our stable, but some resources, depending on what you're looking at, will also say that your silent is like what you can see a lot of as well, but silent, like a lot of them don't even know that they have, okay? So more terms that you'll see, all of these are falling under acute coronary syndrome, or what you'll hear us say ACS as. But when you're looking at this specifically, we hear a lot of these terms used interchangeably, so I just wanted to put it up there. So your heart attack is your MI, right, where you don't get the blood flow going to that area of the heart, and then they will experience, that heart attack. Doesn't necessarily mean that that tissue has died, because some patients, like, it doesn't all the way die in our heart, and our body has a way of repairing itself sometimes. And then we have two different types of MIs that can occur. You have a STEMI or ST segment elevation MI, and then you have an NSTEMI or a non-ST segment elevation. So essentially that will be you looking at your ECG and figuring out if you see that ST elevation or not. And when you see STEMI, you're more so thinking like more serious, full thickness of the heart, like injury, whereas when we're looking at our ST, it's not that full thickness of the heart. Not saying that it's any less serious because it can progress, but you want to, like if you're looking at the difference, the way that we treat them is a little bit different. So we'll go through that as well. This is just again, that terminology that we already talked about, right? So your preload was just before that contraction, the stretch and the feeling, like that amount of fluid that is there prior to you doing your squeeze, and then your afterload is the force that your heart is going to have to overcome to actually eject the blood out of the heart to get it to the body, okay? So again, just a picture, a different way for us to look at it and kind of get those terms down. And then when we talk about our arteries and kind of what they look like, right, because we were saying coronary artery disease is typically what can lead to a lot of these issues that our patients end up experiencing as to why they have some type of ACS event. So normally you see like everything's clear, blood can flow, there's nothing that's going to be impeding the blood flow. And then as you go on, you'll see different fatty streaks and things that start to deposit, and they form what's called a plaque. And so now you have a little, like a slight obstruction. And then as that plaque continues to grow, you see that it gets bigger. So now I'm having to travel through and get past essentially like this speed bump, right? It's not completely breaking it down. It's not completely stopping the blood flow, right? Because my blood can still flow. But now I have this thing to go around. So just think about this thing, your hose that was wide open, now narrowing because I have something else taking up space, okay? And then over time, you see where this can become arthrosclerotic, and this plaque is definitely now limiting how much blood flow can get through there. And then you'll see where you have unstable, or like where people will now become more symptomatic as this progresses, right? Because now my ability to meet that demand is decreasing, okay? Because now I'm becoming more occluded. And then that's when we'll see our unstable angina. You can have your MI, or you could potentially die depending on how bad that occlusion was, and if we were able to get you help or a stent essentially before you die, okay? So, looking at our chronic stable angina, we already talked about this, so what I'm going to focus on is this is background information for you to look at, and it will talk to you about what their symptoms look like. I'm going to tell you what they have, so I don't need you to diagnose. This is just to give you the fuller picture. And then looking down here at what your therapy is in those patients is what I'm worried about, right? So, hey, this person has chronic stable angina, what can they use? They have unstable, what can they use? They have variant, what can they use, okay? So that's all I need you to know from these. I don't need you to go through and remember all of this, because I'm going to tell you they have this type of issue. They have this type of angina. Okay, so our goal. Essentially what we're trying to do is make our patient not have as many of these events. And we're trying to make sure that we can prolong survival, right? I want them to stay alive. I don't want someone to have an MI that could potentially kill them, okay? So I'm trying to essentially reduce these events from happening, these ACS events from happening in this patient so that they can live a healthy life. When we were talking about looking at our non-drug therapy, remember those always come into play. Always make sure that we're talking about smoking cessation, their weight, underlying diseases that we need to make sure of. Their diet is going to be a big thing with this, right? Because as I eat more fatty foods, as I increase my cholesterol, I can have more of that deposit into my arteries that lead to occlusions, okay? That lead to those plaques that could potentially rupture later. So the diet is a big thing, and the diet is one of the hardest things, again, that we are going to have to face to get our patients to change. And then this is just looking at your patients who have that coronary disease and the chronic stable angina. So essentially ABCD, right? So we can give them aspirin, we can give them medications to help with the angina that they feel, like the pain that they're going to feel. beta blocker to try to help also with some of that pain that they may be feeling. And you can also see where we need to maintain their blood pressure, whether that is to, usually it's going to be for us to decrease their blood pressure. Cigarette smoking cessation, diet, diabetes, like what do I need to fix? What are these things that could be contributing to my patient having any of these ACS events occur? Okay? Education, exercise, all of the things. So essentially what we're trying to do is say, hey, if I can decrease the work on my heart, then I can increase my blood flow. And I want to also do that by making sure that my arteries are clear, that they don't have these speed bumps while they're trying to just go through their holes, okay? Y'all will talk about several different ways for you to see different underlying diseases that your patients have. So just understand multifactorial. I'm going to try to just stay in and focus on this is what the title is of that angina that they have, and this is what our treatment is for it, and then you'll get all of the background. So our treatment plan, essentially, hey, what is causing them to have essentially those flares or those unstable bouts that could occur? Make sure that they know, hey, what is your limit? When you get to that limit, you start to feel that pressure, or if you know what that activity is, or that person is that gets you there, like avoid them. Symptom relief, making sure that you're saying, all right, I know that at that time that they're going to have whatever that exertion is if they can't avoid it, or that pain, or they're experiencing it and they have stable angina. We'll give them nitrates. We're specifically looking at the fast-acting nitrates, and those are the ones that are going to be in the little tiny vial. They're really, really small pills. They put them under their tongue, and typically we'll see them like the pain that they're feeling, the angina that they feel, will relieve very, very quickly. So make sure that that's a fast-acting nitrate and not one of our longer-acting medications, because that's not going to help them right away, right? They need help right now. And then our prophylaxis with our calcium channel blockers and our beta blockers, we'll go over this and looking at the difference between the two depending on kind of what your patient is undergoing. And then our aggravating factors, this is just us looking at all of the other things that could be contributing, okay? So always make sure that you're fixing the other stuff too that could be leading to these events occurring, right? And then our prolonged survival, we're going to talk about antiplatelet medications, our statins and our ACE inhibitors. Statins we'll get more into detail in another lecture. We talked about our ACE inhibitors, our antiplatelets, we'll look at them here, and then we'll talk about them a little bit more in our next lecture as well. So this is a good summary slide of all of our different medications that we can say that we're going to use in our patient who has stable angina, okay? This has almost every med that we could potentially use. So we have our beta blockers, which we like first because we have that mortality benefit. If I have a patient who cannot tolerate a beta blocker, or I'm not getting the full benefit from my beta blocker, then I can add on a calcium channel blocker. But our first line when we're trying to pick between our beta blocker and our calcium channel blocker is going to be the beta blocker because it has that mortality benefit, okay? Now, if I told you that there was some type of contraindication as to why they couldn't take the beta blocker, then okay, we have our calcium channel blocker here, right? But our first line, because of the fact that I have that mortality benefit, is going to be my beta blocker. My nitrates, we just talked about those. Essentially what they're going to do is they're going to decrease that demand that we have on our heart. It's going to kind of open things back up for your patient, relieve those symptoms a lot better. But when we're looking at this, when we're, our short acting is going to be like immediately on hand, like I can take it sublingually, I'm going to have some relief. When I look at my long acting, those are more so for like maintenance, where we can add those to our beta blockers and make sure that we aren't using our short acting as often, okay? If you have a patient who's coming in and they're needing constant refill on their sublingual nitroglycerin, that means that they're not as stable as we think. So we need to check their medications to make sure that they're taking them and that they're on the right dose of them, okay? Because think of your sublingual nitroglycerin as like a rescue inhaler, okay? This is like their rescue for our stable patients. It is immediate release versus your long acting. Your long acting is more so what you're using for your maintenance with one of your beta blockers. Your sodium channel blockers, specifically looking at your ranolazine, just understanding that these are like more so second line. So I'm not getting the response that I want from my meds on the left, and therefore like I'm adding on this treatment. It's not something that I would be like, oh, I'm just going to use this as like a standalone medication. Your ACEs or your ARBs, again, we look at these for patients who have several different comorbidities, looking at CKD, diabetes, hypertension, all the things that we have kind of already talked about. So you'll see the ACE or your ARB listed here. And then our statins, which I told you again, we're gonna go over that. But those are our meds that are gonna help with the cholesterol and that plaque buildup that we can potentially see. So it's gonna help us reduce the possibility of our patients experiencing one of those MIs. And then your antiplatelet, this is again trying to stop or prevent the formation of a thrombus or a clot from forming. And we're going to talk about these again when we do our next lecture also. So make sure that you understand that unless there's some type of contraindication, almost all of your patients will end up on an antiplatelet, which is a very common one. We'll use a low dose aspirin in these patients. Clopidogrel is another option, more expensive than our aspirin, bless you. But our aspirin is the one that we will typically see our patients on whenever they have any type of IHD. Okay, our beta blockers. So when we're looking at this, we have seen this slide. Now this is like the third time that we have seen this, right? So same information, but when we're talking about it in the sense of angina, we're saying like, hey, help me decrease this oxygen demand that I'm not able to meet that's causing me this pain. So that's what they're doing. They're going to slow down that heart rate. They're going to slow down the blood pressure, decrease that contractility so that my demand in my supply aren't so far off, right? I don't have that bigger gap. It's kind of making it a level playing field. And then remember that it has that survival benefit, which is why we are going to prefer this over looking at one of our calcium channel blockers, okay? So one of our first line meds that we're going to use because of that decrease in the demand that we experience. We talked about the different agents in our different classes that we had. So our beta 1, our mixed, and then our non-selective. And then looking at this, you see that when we look at our ISA, we're saying, hey, I don't want to use this in my angina. And the reason why is because it can worsen the bronchoconstriction that these patients are already experiencing. So that's why we kind of will try to avoid this drug class. Also, remember your contraindications over here. Don't worry about remembering that PR interval. I'm not asking you about PR intervals. I just want you to know, like a person who has bradycardia, they have any type of heart block. I'm not going to be like, oh, they have first degree versus second degree versus third degree and trying to make you remember that. I want you to remember heart block. Decompensated heart failure, our asthma patients, the same things that we already saw, okay, are our same warnings that we have, and then just making sure that you remember to avoid our ISAs in our patients with our angina, because we're sick. Again, we already saw and looked at this. Make sure that you're looking at the fact that we want to decrease or minimize that O2 demand, but we won't get enough minimalization when we're using our ISAs. So that's also why we don't like to use that, because remember our ISAs also had some agonism in there, right? It was a partial agonist. So we don't want to see that whenever we're already in this situation. So that's why we don't like to use those as well. Precautions, the same ones that we've seen already. Sexual dysfunction, we're going to talk to them. Our asthma patients, make sure that they're stable because we can increase the chance of that bronchoconstriction. Your diabetic patients, making sure that you're understanding like, hey, I can mask those hypoglycemic effects and make it more difficult for them to recover from those hypoglycemic episodes that they may have. So just remembering the same things that we talked about previously. Avoiding our, which ones? What are we avoiding? ISA. Okay. Calcium channel blocker, first line, second line. Second line, or if there's some type of contraindication to my beta blocker, that's the only way that it becomes a first line, is second line, because I don't have my mortality benefit. So again, looking at here, same things that we already talked about. Again, we are trying to decrease that demand. So what I want you to pay attention to here is the the short-acting nifedipine should be avoided, okay? The reason why we're looking at that short-acting nifedipine being avoided is because it can end up causing reflex tachycardia, which could then lead to death in my patients who are already having angina, okay? So we're gonna go over the different formulations, can't think of the word. Go over the different formulations that we have available for what we're going to use, because now that's coming into play. Now we're going a little bit more microscopic than those big pictures, right? Now we're saying, okay, I can't use this in this disease state. Same drug, but I can't use this one, and here is why I can't use it. Remembering why we can't use it also is important for us also. Looking at our inotropy, remember our VRAP and our DILT were our ones that were non-dihydropyridine or non-DHP. Those were the ones that also had the effect on the heart, okay? So that's why you see that's the only ones that you're going to get that negative inotrope effect from. Our clinical use, okay, so essentially what we are saying is that we are decreasing our vasculature resistance, and therefore we have less O2 requirement. We're decreasing the consumption that we need. So again, second line medication, we like our beta blockers. Our nitrates are very effective when we're looking at those as a class also, because they work quickly, especially when we're looking at our sublingual ones, okay? So again, make sure that you understand that this is like an add-on. I can add this on to my beta blocker, but I'm not using this. If I had both as an option, I'm going to pick my beta blocker first unless there's some type of contraindication as to why I can't pick my beta blocker. Then I will look at my calcium channel blocker. Preferred drugs for our Prinzmetal or our variant. Remember, our variant were those little spasms that our patient was having. This is very good for that, because remember we talked about the vasodilation that we're getting when we're looking at this. I'm decreasing the vasculature resistance. And in our patients with the variant, they're having those spasms. So when I'm spasming, I'm doing this and I'm closing. If I have on my calcium channel blocker, I decrease that resistance, right? I'm letting my vasodilation happen. I'm not having as much spasms. So that's why you see this one is the most effective when we're talking about our Prinzmetal or our variant. Okay, we've seen this before as well. Making sure you're understanding the difference between your non-DHPs and that you have your verapamil, which is less selective. So when we're talking about our selectivity, so you're going to see typically more decrease when we're talking about that heart and that vasculature than when we're comparing it to our DILT or our diltiazem. That was not as strong. Other than that, like, these are options for us to have, and we like them when we're talking about angina, because these are the ones that are going to be selective for the heart versus us getting a lot more of that Sorry, I thought it's instead of us getting that a lot more vasodilation when we're looking at our DHPs, okay? So for these patients, we like seeing that non-DHP, because I'm having an effect on the organ that I'm having a problem with, right? I have more of an effect on my heart, so I'm looking at my non-DHPs more. When we're looking at our DHPs, remember they ended in P, right? So what I want you to remember is FAN, okay, F-A-N, right? Felodipine, amlodipine, nifedipine, and specifically looking at nifedipine extended release, not my immediate release, okay? So I'm looking at these meds because these are longer acting. I want things that are going to be longer acting when I'm looking at my angina patients. So that's why these are preferred. When you're looking at your nifedipine, it can worsen what those patients are feeling if you're using the immediate release. So you can start to have reflex tachycardia, which is what we're already trying to get that patient back down. And so what I could be doing is, making this situation worse for them when I'm using my short acting. So my nifedipine is my long acting, okay? So FAN, felodipine, amlodipine, and nifedipine, these are the ones that we studied specifically dealing with our stable angina. So take what we did previously in all of our other lectures, right? We had a wide array of options, and now we're more microscopic and saying, this is what I'm using for this condition, which formulation can I use of it, and which particular medications can I use for it, because now I don't have the whole menu. I'm selective for what I can use in this condition, okay? So I could give you a different calcium channel blocker, or I could give you a nifedipine that's not an extended release, and wrong answer, right? Because that's not what is indicated specifically for my stable, okay? So I want to be a fan when I'm looking at my chronic stable angina. Mechanisms, all of this over here are things that we already talked about. So again, just remember they're in combination with our beta blocker if we're not getting the effects that we want to see from our beta blockers. And then understanding that if there's some issue as to why I can't use my beta blocker, then I can use one of my calcium channel blockers. Remember the difference between your non-DHP and your DHP. Again, side effects, we already saw all of this, your interactions. Again, with the digoxin, so your digoxin, remember a narrow therapeutic index drug that we're going to talk about more in our next block of instruction. But just to make sure that you're understanding that this drug, digoxin, interacts with everything, but your calcium channel blockers can increase your digoxin levels. And depending on where that patient's levels are, that could throw them outside of that therapeutic range. They could end up having a lot of toxic effects, and they'll start to display different symptoms for you. So we typically will measure our dig levels. And if you start a calcium channel blocker on a patient who's already on digoxin, please make sure that you're monitoring their digoxin levels to see how it's going to affect that level, because 20 to 70% is a huge range. Where are they? Where is that patient on that scale of variability, right? Because that's huge. So that's the bigger ones that I wanted you to look at there. Remembering that if we're combining our calcium channel blocker with our beta blocker, that we want to choose a DHP or a non-DHP? DHP, because our non-DHP with our beta blocker can do what? Cause what? Bradycardia, right? You're gonna drop me too low. Okay, we don't need class today. All right. Our nitrates. So a big thing here now for us to focus on is looking at this mechanism. Essentially, when we talk about our nitric oxide, what it's going to do is it's going to relax the smooth muscle. It's going to increase our oxygen supply that we have because we have now more vasodilation that's occurring. Okay? If I can do that, I'm now meeting that demand. Because remember, my issue in our IHD is that my demand is not matching my supply. Okay? My patient does not have what they need. This is making it, again, a more level playing field. Decreasing that pre and that afterload, and it's also going to help them not have as many spasms if the patient is experiencing any type of spasms. So this is just looking at, again, what I was just telling you, decreasing that the preload, because now I have more dilation, and therefore that oxygen demand, that burden isn't going to be as heavy for these patients. Okay? So they get a lot less work that they have to do, and it also, a lot of patients, whenever they take the nitroglycerin, it's kind of like you see their face completely change, because it's like a relief of the pain that they're feeling, almost like within the first minute or so of them taking it. Okay, so very, very good meds. The only thing that I want to caution you about whenever we're looking at this is that make sure that their medication is not expired. Hopefully it's not something that they're having to use very often, and so they'll have this little vial, and it's a little small tiny vial because the pills are super small. Because they don't use it often, they don't check the expiration date of it, right? And so if they've never opened it, they're like, oh, it should be fine. It's probably good. And then they go to reach for it, and then it doesn't work because it is now expired. Worst thing that could happen, okay? So make sure that if you see that it's been a while, 6 months to a year of you like having to, where you prescribed it or someone else even prescribed it, you're like, hey, make sure you go and check the expiration date on your nitroglycerin and make sure that it's not expired. If it is, I'll go ahead and I'll refill it. And typically what I've seen providers do is they just put a refill for it on their profile, on the patient's profile, so they don't have to call you back, they can just go and get that refill. Remember, that prescription will be good for a year on their profile, so they don't have to really bother you, okay, and come back, because you know that they're going to need it at some point. Sometimes the pharmacy, so we pull out sometimes 90 days, 3 months ahead of when something expires. So I could have potentially given them something that was short dated that was only gonna last for 3 months from the time that they picked it up. Or I could have given them something that just came in because we have a high turnover of it and it doesn't expire for another 2 or 3 years. Okay, so it varies, so that's why also for you, make sure that you're just checking in the patient. So looking at our clinical use, you have your stable and your unstable. We're talking about our Prince metal and using it there. So when we're looking at our stable, you see that we can have it in conjunction again with that beta blocker, like I told you when we were discussing the beta blocker, or if we were looking at one of our non-DHPs. This is essentially to help them meet that demand level. So if I'm fine with just my beta blocker as like a maintenance med, that's okay, you can do that. Most of the time, I will see that somebody is still on a nitrate because I don't want them to get to the point to where they're using their sublingual nitrate, right? I don't want them to be like, oh my gosh, can't breathe, I need my nitroglycerin, okay? So usually you will see this added on. If you see your acute situation, this is the ones that I was telling you. Typically what we see prescribed and what I dispense is the sublingual. We do have the option for the spray, but the sublingual is just a lot easier for them to carry around. They can keep it on their person. Like, I mean, it's literally like a vial that's this big with 25 tablets for them. So that's a lot easier for them and more convenient than carrying around the spray, which is like a bottle with this like a attacher on it for them to spray it into their mouth. At least I know that it's all getting to where it needs to go. Both of them do act quickly, so it's not that one is better than the other, but it's just more patient friendly, the sublinguals. And then looking at your prophylaxis, if somebody knows what is causing them to have that exacerbation, right? I can give them this medication prior to so that I can already allow them to meet that demand when they do start to work out, okay? So that's what you see here, giving it prophylactically, all right? And then my unstable and my variant, my sublingual, again, my spray, so my more immediate release options are what I'm going to give for these patients to try to help them. And then IV, if somebody is in an inpatient setting, again, if they're conscious, we'll still give them that sublingual or the spray. But if they have a line that's available and free, definitely an option for us to give them that IV formulation. Looking at our PK, we talked about these, specifically looking at our oral, that we had that first pass, so that's typically why you won't see like a tablet that they're swallowing. So this is one of those ones where it's very important for you to tell them it's sublingual for a reason. Stick it under your tongue. Do not try to swallow them like most people do with sublingual meds. Like a lot of people will swallow them. If they're taking it for a migraine and they want to wait that long for it to work, fine. But when their heart is hurting, they need to take it how they are supposed to take it, sublingually, okay? Because I'm also worried about my first pass effect if I did take it that way. You see that we have all these different formulations that we talked about before. Big thing that we were worried about here was looking at the fact that tolerance can develop, especially with that use after that first 24 hours. So that is again why if you see that somebody is using one of those immediate release a lot, then you need to start worrying about, okay, what do I need to do to maintain them? Like I don't have them on enough maintenance drugs, or I'm not on the right doses. What can I do to try to help them meet that demand that they have? Because I don't want to use these nitrates, especially my short acting, for a very long time because I have the potential to develop that tolerance. And that tolerance is due to the aldehyde dehydrogenase, or ALDH. Reason why I added this in there is because you have, again, the Asian descent population. So remember, we look at certain things and when we need to be like, hey, my antennas need to go up. So with this, what you'll see is that they don't have as much ALDH allele activity. And so therefore, the nitrates aren't going to be as effective as what we would typically see. So that's something that's important to know, because if I'm giving you this sublingual and I'm like, hey, use this, and you go and you use it and it doesn't work, you want to know that ahead of time. Okay, so just make sure that you, if you can test for this, look at that and make sure that they are able to tolerate it, and that there is cross tolerance. So if I am taking the spray and then you put me on the sublingual, they're still the same med, right? So I can still develop that tolerance quicker. And you switching me to a different formulation isn't going to make my tolerance any less prevalent, okay? So understand, the longer you use it for a straight period of time, the more likely you are to experience that tolerance within the first 24 hours. This, looking at your patches, so this kind of reminds me of lidocaine patches as well. If you ever had to use a lidocaine patch, you put it on for 12 hours, you take it off for 12 hours. Same exact thing when we're talking about our nitroglycerin. Put it on for 12 hours, take it off for 12 hours, because that's why we're, and the reason why we're doing that dosing is because we're trying to avoid that tolerance, so we're giving a break. Important thing with this, make sure that they're not putting other creams underneath their patch. Some people will be like, oh, it's kind of like a Band-Aid. Like, I'm going to put this cream on and then I'm going to put my patch on. Just put on their patch, okay? You don't want to put anything else there, because we're trying to make sure that your nitroglycerin is going through for your maintenance drug. You don't need to be putting anything else on there. Also, make sure they take it off. So I tell my patients, hey, set an alarm every day that you're putting it on here and you're taking it off here. It's a part of your routine, because the longer that they leave it on, more likely it's going to stop working, okay? So we don't want to do that. And that's any dosage form that can develop that tolerance. Adverse effects, the biggest one that you're going to watch out for, and this is a common thing that we see in a lot of our meds, but remember I told you typically I may not ask you like, oh, about a headache. But you see that this is the most common side effect that we see when we're talking about our nitrates, and that's because of the vasodilation. So that's a big deal, because you may need to tell your patient like, hey, the first couple of weeks of you taking this, and this is more important for your patients who are taking it in a maintenance form, the first couple of weeks of you taking this, you may experience more headaches. But over time, you will develop tolerance to those headaches. Your body is going to say, all right, like, I got it, we're taking this, I'm going to get used to it in a second, and it'll stop the headaches, okay? So that usually takes a couple of weeks. So tell your patients to kind of hang in there. If they can't tolerate it, then of course, take them off, but we typically won't see someone who is off of it because of that, because they do subside. Flushing, again, think about the vasodilation that's happening. All of these make sense, right? I've opened everything up, and so now I can expect that blood pressure to drop, so that's why I can see the dizziness, the hypotension, all of these things make sense. We already looked at this when we were looking at the increased ICP and the methylglobemia, and then the potential of the reflex tachycardia, especially if I'm giving it, if I'm giving this alone. We typically are not giving this alone because they're going to have that beta blocker. So the beta blocker will essentially sometimes mask or stop this side effect, you from seeing this side effect even occur. So most of your patients are going to be fine if that's not all that they're taking. Bless you if that was a sneeze. Your contraindications. So this is where we get into it with our patients who come into the ER. And you hope that they're in our system and you can see what medications they have. Because a lot of times when patients come in with chest pain, that's one of the first questions that you'll hear people ask is, are you on any PDE5 inhibitors? You cannot ask them that way. Do you take Viagra? Do you take Cialis? Like, do you take anything for sexual performance? And most people are going to be embarrassed to say yes. When people are asking that, I go to the profile and I'm like, please let them be seen here. Sometimes people realize like my heart is in trouble and I just need to be honest, who cares? And other times people are like, I'm just gonna die with it. Like, I'm good. And they won't say anything. We're worried about this because it can essentially like, you're causing too much vasodilation in this patient, and therefore you can bottom them out. Like they can become extremely hypotensive. And if they say yes, you say, okay, how long ago did you take it? Right? Because am I worried about it if they took it like a week ago, depending on the half-life of them? Not really. So I'm okay, and I'm going to go ahead and I'm going to treat my patient. I'm not as cautious as I would be if I were to push like nitroglycerin or give them something like this and I didn't know that, okay? So, yes, everybody is going to be asking these questions. Please don't make sure you give them the class. Don't say a PDE5 inhibitor or a phosphodiesterase 5 inhibitor. Say the drug to them. You can say the brand, you can say the generic, because most people know these meds by their brand name because that's how they like marketed them so much. but ask them to see if you can get that answer. And while if you see everybody else is like hands-on, because there's going to be a bunch of people in there, you can start looking and seeing if they're in our system. And then just do that med rec real quick. Be like, okay, do I see anything in here that is going to be a contraindication? That's one of the biggest ones. Your patients who have cardiomyopathy, inferior wall MI, you're going to go over more of this stuff. And then your stenosis, again, are things that we're worried about in our contraindications in our patients. Okay, that cardiomyopathy, what could happen in those patients is that you could see like worsened outflow instead of the better outflow that we would typically want to see. Same thing with stenosis, right? If I'm hardened, I'm not going to be able to vasodilate. I'm not doing anything with this med, but giving them side effects. Okay? Several different formulations. We have lots of them. Okay, this is the vial that I was showing you that it comes in. I want you to look at this dose, and I want you to remember this dose. I know I don't tell you a lot of them, but this is one of the ones that I want you to know. So when you're looking at your sublingual, you see that they're going to take one tablet when they start to feel that pain. Okay, and then they repeat it every 5 minutes if that symptom persists. Now, sometimes what we tell patients is, hey, you're not allowed to take more than 3, right? Once they get outside of that 3, they need to be making their way to the hospital or calling the ambulance, okay? Because my nitroglycerin should open them back up. I should be able to help them. If they can't do this, and this is something that they have at home, I should state that. This is something that they have at home. So if they don't see like any relief after that first tablet, tell them they need to start calling 911. They can still take those other 2 doses and not be at the hospital, right? Because it's going to take time to get there. So they're either transporting themselves to the hospital or they're calling 911. If I took that first dose and I'm seeing absolutely no relief at all, I need to start calling. So no more than 5 minutes. They should be seeing a response typically within the first minute or 2 of them taking it. But if 5 minutes have passed and they're on that second dose and they had no, they should be on their way. Somebody should have been called or they're in their car. And then the sublingual again, or sorry, your spray, that's when you're just spraying in your mouth to get the dose. Same way that it's working, but again, this is the one that you'll typically end up prescribing, super small. Another thing with this is that when we give these to our patients, I know a lot of patients have like pill boxes, right? That is not something that goes in a pill box. This is something that we always try to protect from light, which is why you see that vial like very dark in that dark amber glass vial. You want to keep it in that original vial that it comes in. They should not be taking it out of there unless they're taking the actual tablet. And then we want to protect it from light so that it keeps the integrity of the pill and the strength of the pill. It doesn't degrade it. Okay? So 2 very important things. Keep it in the original vial, okay? Always stay in the original vial, and that they need to make sure that once they open it, that they're keeping track of it because the potency is going to decrease the longer it's been since they opened it. So let's say they cracked that bottle and 6 months has passed. Typically, I'll tell my patient like, hey, just go get a new one. Because now air has gotten in, more air than whenever they closed it has gotten into that bottle. So our patient education, exposed to air and light, we're going to lose our potency. Our spray is more stable, but again, that's not the one that we will typically see prescribed. Y'all are typically going to prescribe the tablets. So it will be something that you will start to develop a preference for, and then you talk to your patient, ask your patient like, hey, which one do you prefer? If I give you this is more convenient, right? It works very well, but you got to make sure that you're checking the expiration date, which you got to do that for both of them anyway. But once you open this, we need to make sure that you know to go and get another one, okay, after that 6 months has gone by. They're going to use them, and a lot of times you'll see these thrown away. Please make sure people throw them away and that they keep them away from kids. I have had several patients who call the pharmacy because kids have taken their nitroglycerin because they're super tiny and they melt in your mouth, literally melt in your mouth. So by the time the kid can think to spit it out, it's probably already starting to disintegrate, okay? Like, well, how old were they? Does your kid look like they're tired? Like, no, they're still fine. You're probably all right, but you can go ahead and go to the hospital because there's probably 25 in there. Most of the time, people don't even know how many are in there. It could be 10, because remember, this is as needed. It could be 15. Nobody ever knows. So, big thing, throw them away if they're not good. Don't leave them hanging out in your purse, like with access, or your pocket with access to children. The standard practice, don't use nitroglycerin that are more than 6 months old, since the potency may be decreased. And this is more so once you have opened it. And then looking at your administration, sit down, place it on your tongue over all the things. Most people who are used to this and they have stable angina and it's chronic, they don't typically sit down when they take it. But the reason why we're saying that is because I'm going to do what to their blood pressure. And then, depending on how fast that happens, they might drop too, okay? We don't want problems. We don't want no smoke, okay? Relief should occur within 5 minutes. Like I was telling you, a lot of the patients, like they'll tell you within a minute or so, like, and you can see their face. It's just like a sense of relief. After that first dose, they should be doing what if they don't have any relief? 911 or on their way to the hospital. Don't let them tell them to drive themselves. Call somebody because I don't need them crashing into me because they passed out. Okay. This is looking at our IV formulation. We kind of talked about this the other day. Mechanism of action, same thing. We have that nitric oxide forming, which is then going to decrease that the O2 demand. We have the preload going down. We have some vasodilation that is occurring. So essentially, this is making it again the same playing field. Short half-life for this medication, just like most of the other ones that we talked about, and then that tolerance. Because remember, I told you already, it doesn't matter what formulation you give me of the nitroglycerin or any of my nitrates. I can develop tolerance to all of them typically within 24 hours, but it can happen within that. I can have to where it goes up to 48 hours, but typically it's that 24 hours that we'll see this. Clinical use, again, all of these listed here. We talked about this when we were looking at our hypertensive emergency. We talked about this whenever we're looking at heart failure. We can also use it in this situation if we have somebody who has presented to the hospital and they're taking their orals, but now they're in your care, you have a line, also an option for you to use it. Adverse effects, we're more likely to see that headache that we talked about and the vomiting. The faster the rate of this, the more likely you are to see these effects occur in those patients, okay? And then there's our methylglobinaemia again, which we talked about already. So more so, this one is like if your patient is inpatient, of course, because it's IV. And then also if we're talking about a patient who has pulmonary congestion, this is better for them because it's also going to help relieve. Remember how we were talking about this in our heart failure, right? So pulmonary congestion, the patients are the ones who would benefit very greatly from this. More options that we have, okay? You have your patches. This is more so for the ones who are going to be using this in conjunction with their beta blocker. And then this is an interval as well, right? So our 12 on, 12 off is typically what we tell people because it's easier for them to remember that. We have 12 to 14 here on the label, but typically I just tell people 12 on, 12 off, 12 on, 12 off. That's easier than you being like 14 off and then wait 6, it's too much. Wait 10 hours and then put on another one. Oh, well, I woke up at a different time today, and so then 12 on, 12 off, okay? Make sure that people understand with this medication that they cannot cut the patch. It's already like a little small patch, but people will try to cut the patch, okay? If they can't afford it, they should be talking to you about it. Ask them why they want to cut the patch. Because then what happens is that system that I have that drug going through to diffuse into their body has now been altered. And so them getting this medication and how we want it to slowly deliver over that 12 hours is now also altered, okay? So just make sure that they know, do not cut the patches. Ointment, another one that you see here, more so for our patients who are inpatient. Even inpatient, we don't use this like a whole bunch, but it's definitely available. You see that we still have to worry about our 12 on, 12 off, okay? So we need that period because we're trying to minimize the tolerance that they experience. So we give that ALDH time to kind of rebuild up again, And so that's what we're doing in that 12 hours that we're off, is that now I can have more stores of that again, and then I can give them another dose. We're going to take our break because it's been 15 minutes. Take our break, we'll come back doing that one every day, right? So that's more compliance typically that you will see with your patients when you're looking at your extended release versus your regular or immediate release medications that we're talking about, okay? So if we're talking about an acute episode where somebody is feeling like that sudden burst of pain, these are not great options, right? Because I have to go through ADME. I got to go through that whole process to get broken down to be effective versus you using one of my immediate acting like sublingual, okay? So that's the big difference when we're looking at this here, is like it's more so for your patients who are stable, who are using this as like a maintenance medication. Imdur, okay, is the mononitrate instead of the dinitrate that we just talked about. Same idea of when we're using it. Not FDA approved for our heart failure patients, like we saw our dinitrate in the combination with our hydrolysine, okay? So that's the big difference between those two. We also have the regular release versus or immediate release versus your extended release. And again, we're seeing the benefit of us having that everyday dosing. Just take a note on this regular release and how you're looking at this. And I don't need you to remember this, but I just want you to understand, when you're looking at formulations, always think about your patient. Do you think that somebody is going to remember, because twice a day, remember when I talked to y'all last semester, I said, when you're writing twice a day, typically it's better for you to write every 12 hours, right? Because twice a day versus you giving it to me and I take it at 8 o'clock and I take it again at 10 o'clock, okay? Because that was twice that day. This is confusing to some people because you're going to write BID dosing, give second dose 7 hours later. That's not typical. So your adherence in the way that your patient should be taking this, they're probably not going to be very adherent. So if you see people coming in and they're telling you like they're having to use their sublingual or their spray more often, you should be like, oh, well, tell me how you're taking it. Oh, I'm taking it twice a day. Yes, but like, how are you taking it? Okay? Because that is very specific that second dose is 7 hours after, not a typical 12 that you would normally see. So for me, when I see something like that, I'm going to say, I'm going to give you extended release because I know that I have a better chance of having my patient be compliant. Okay? All right. This was just showing you all of the different drugs that we looked at, right? All of the different formulations that I have. I only wanted you to remember your doses for your nitrostat, which was the same as the pump. They were going to take that tablet, they wait 5 minutes, and they have no more than 3 tablets that they can take in that 15 minutes. Make sure that they know that they need to call for help or go get help if they don't see any decline in that demand or the pain that they're feeling after that first 5 minutes or that first dose that they took. Okay. Ranolazine. Okay, so we talked about ranolazine a little bit, our sodium channel blocker. When we're looking at this, it's decreasing that calcium influx by stopping the inward sodium channel, okay? So therefore, I have less calcium coming in, I have less tension on the wall, and therefore I'm not using as much, my demand is now decreased, okay? So that is the big idea behind this. If I can keep if I can keep calcium out, I'm not having as much demand. Remember with digoxin, we were letting more of that calcium in so that we could have like a bigger squeeze. This is like, all right, we already hurting. I don't want to squeeze too much, so I'm blocking that inward calcium channel from happening. Antiarrhythmic properties are something that's going to be good because in these patients, depending on how bad they're having that spasm or that pain, I can end up having an arrhythmia occur. Make sure you remember this, that this has nothing to do with your blood pressure. No blood pressure effects. We're focusing on those sodium channels and we're focusing on the effects that that has on that calcium, okay? Maybe added to any of our other therapy that we have on board. So if I have them on a beta blocker and one of my long-acting nitrates, I can say, okay, cool, I have them on this calcium channel blocker too, still not working, I may end up at ranolazine. So ranolazine is like down the line, okay, as an option that we could use. When you're looking at this with this clinical use in this top one, as far as like us choosing ranolazine or a calcium channel blocker, there is really no wrong answer. More people are going to lean towards a calcium channel blocker than using this ranolazine. Again, it's a preference thing. I have seen people go both ways in real practice. Okay? Adverse effects, the same ones that we already talked about. Because it doesn't have a lot of effect on that heart rate or the blood pressure, we're not as concerned about that bradycardia and hypotension. So if you have somebody who's already in that state, this may be a good option for those patients like we talked about before, okay? Because I don't have those pronounced effects. Looking at the dose-related QT prolongation, please watch out for drugs that cause QT prolongation, especially in patients who have cardiac issues. That is something that we want to make sure that we're watching out for, because we can have drug-induced arrhythmias that could potentially occur. Usually this is with a higher dose that we would give somebody. When you remember SIPs, and I talked to y'all about SIPs last semester, just remember a lot of interactions, okay? This interacts with several drugs. Make sure that if they have any type of liver issues, that we're being careful with that, because I might have to change my dose because this is renal clear, or sorry, you have liver, the metabolism of the medications, okay? So avoid use there. We talked about these SIPs, so just make sure you understand it has SIP interactions. Don't need you to remember 2D6 or your 3A4, just SIP interactions. And then that QT prolongation, you see where we're trying to limit the dose in which we want to dose our ranolazine, because we can have that QT prolongation, which could be very detrimental to people. These other medications that you see here, your non-DHPs, erythromycin, fluconazole, grapefruit juice, the reason why you see those there are those are also things that can cause QT prolongation, okay? So those are other common drugs that we talked about last semester that you could see the QT prolongation in. Our non-DHPs, the reason why you're seeing it here is because now I'm adding on that potential effect with ranolazine having this property by itself. So just be cautious of it. If you take a baseline, again, when I tell y'all some of these contraindications, there's different types of contraindications. You have relative and you have absolute contraindications. I'm just telling you, like, blanket, here, this is a warning, or this is a contraindication in that sense, and kind of keep, or a caution sometimes is what they are too. So just keep them together that way. I will, if I want you to like know, like this is an absolute contraindication, I'll have it on the side that says absolute contraindication. You can see where people will use these things together, okay, and they just monitor their patient. Unstable, or acute coronary syndrome, or what you'll see abbreviated as ACS. So most of the time when we're looking at this, it's going to require more aggressive treatment. Your patient is going to be in a lot more pain. As they start to move more, they'll start to experience more of that tightness and the pain that they're feeling. So again, what I'm expecting for you to know is, here's this disease state, and these are the meds that I'm using for it, okay? You don't have to know all of this stuff that's in here. We kind of went over what this looks like already. So we were talking about, like, all right, I have this, my endothelial cell, everything should be fine. As I start to build up that plaque, and I start to have more fatty deposits, which is what is contributing to the plaque, I start to get more of a occlusion. What happens when we're looking at our ACS is that this cap ruptures and it can form a clot because now things can't flow through well. You want to catch it before it can occlude different areas. The smaller that that rupture, like depending on how that plaque ruptured, it can go and occlude smaller arteries and veins, okay? And then that's where you'll start to see tissues dying and different things like that. So we're trying to essentially make sure that if we have somebody who is in like this unstable realm, that we are treating them as soon as we can And a big way that we know this is your patient is going to suddenly start to feel like they're short of breath, okay? And then that's why we need to treat them in the hospital, okay? So this is our unstable angina, more serious of how we're trying to treat our patients. So stable, that plaque is kind of solidified, it's stable. It's like, you don't mess with me, I'm not messing with you. But you always have the potential for it to progress, to lead to total occlusion, to lead to some of that unstable and STEMI death potentially. So as you look at this is kind of an easier way for you to remember this. This probably shouldn't have been read, but it says right here, like let's say that plaque ruptured, that's when you kind of progress into that ACS territory, okay? We want to try to limit the chest pain that these patients are going to feel, and then depending on how you're going to treat them, that will vary depending on if it's a STEMI or an NSTEMI, okay, in that patient. And that you're going to get whenever you're doing your ECG, whenever they come in complaining of the chest pain, okay? So that's how you'll figure out kind of what you're going to be doing. This is again just showing us that action of what's happening whenever that rupture occurs. Don't need you to remember that. And then now talking about our unstable, specifically looking at our NSTEMI. So what we're trying to do in this situation is we didn't see that ST elevation, but we want to make sure that we don't have that occlusion occur or total occlusion occur for our patient. So what we're going to try to do is have antiplatelet medication be given to our patient as soon as we can. So essentially what your antiplatelets doing is they're blocking your platelets, okay? You don't want them to like stick together, right? And then form like that clot to where it occludes. We're trying to prevent total occlusion. So if I have my antiplatelet on board, that could be aspirin, that could be your P2Y12 receptor inhibitor, and then you also see your glycoprotein 2B3A inhibitor, and we'll go into more detail about the examples of those. But I can give my patient any one of these antiplatelets to make sure that yes, I had that rupture occur, my patient is in pain, but I am preventing that total occlusion from happening, okay? I want to make things not sticky. So when you're looking at this antiplatelet, in the absence of an absolute contraindication, these are the medications that we're given. So when we go over our meds, we're going to say, okay, which ones can they take and they can't take. We're going to go into some of these in more detail in the next lecture also. So kind of, we'll see this again. So your P2Y12 receptor inhibitor, a very common one that you're going to prescribe is going to be your clopidogrel or Plavix. We'll see this a lot. It's going to help try to make those platelets not get activated, because once they activated, just think of them like, hey, everybody come and stick to me. They're like waving their hands to catch whatever they can to form a clot. So what we're trying to do is say, hey, I don't want you to activate to put out your feelers to everybody to come around. Think about an ant. You know when you drop food and like you see one ant and then there's like a million of them all of a sudden they're carrying that piece of food away? This is like our platelets, except they're not carrying the food away, they're blocking wherever they aggregated at, okay? So we're trying to not let them put their fillers out to the other platelets to come there and occlude that area. We want it to stay open, okay? So you have that, and then you have your glycoprotein 2B3A inhibitor. Integralin, these are more so like our very aggressive medication options that we have. This is less aggressive whenever we're talking about it. Again, preventing that formation and the aggregation that we have of our platelets. We don't want a clot. When we talk about our anticoagulation, so warning is that people mix these two things up. When we're looking at platelets and like a plug, like think about, we're trying to make that platelet not be able to form this clot and occlude this area. Whereas when I'm looking at anticoagulation, I'm trying to say like, I want this blood to continue to flow and not make a thrombus either, okay? Like keep the blood flowing, kind of think about like thinning the blood, okay? So your anticoagulation is working on coagulopathy, whereas your antiplatelets are working on platelets, okay? Working on not allowing those fillers to get out and get everybody to come to the party, okay? We don't want it to happen there. So our anticoagulation, all of our patients who have our NSTEMI are going to be on there. As soon as you can get them on the anticoagulation, the better, because remember, something ruptured, right? It ruptured, and I don't want this to get worse. I don't want anybody else coming to the party, and I need my blood to remain thin, because the thicker it gets, the more likely I am to have more issues, okay? So you have your antithrombotic therapy that you have. We'll talk about all of these different types of anticoagulants, different types of heparin that you'll see, low molecular weight, unfractionated heparin. We'll go over them. There's different types of ways that you can give them. You have different options. We have oral options. We have injectable options. So we'll talk about that. But essentially, we're just trying to make sure that we are keeping everything flowing. What I want to make sure that you understand is that we are not using any fibrinolytics. When we talk about our fibrinolytics, we're going to talk about that when we're looking at a STEMI patient. So don't get them mixed up. Okay, this is specifically looking at your patients who have NSTEMI, so underline, circle NSTEMI, because when we talk about STEMI, our meds are going to change just a little bit. Okay, so we're just having our antiplatelets plus or minus the anticoagulant if they're experiencing that NSTEMI. Because I can just be an unstable patient and you have me on my antiplatelet. Now, you will hear antiplatelet called DAPT, D-A-P-T. So that's dual antiplatelet therapy, okay? You'll see that sometimes also. Dual antiplatelet therapy. Remember, my aspirin was already an antiplatelet. When I add on my P2Y12 or my G2B3A, those are also antiplatelets. So I say dual or DAPT because now we're going to have them on two. They're going to be on aspirin and that other antiplatelet medication. Okay, DAPT, DAPT. So when we're looking at this, usually they're going to get surgery because you're going to need to kind of open back up that area for them to make sure that they can that they don't progress to a STEMI if that is the case. So what we do is we'll do a PCI or a percutaneous coronary intervention on those patients. I'll let y'all get into more detail. It was just for completeness as to why it's here. But they will have a stent. And then there's two types of stents where you can have the bare metal, which just is going to like keep that artery open. And then you have your drug-eluting stents where we have medications that will be on those stents to kind of continuously maintain the patency of whatever that area was that was previously occluded. Okay, so it's just opening it back up, and we have medications that's going to continue to come off of that stent. So y'all will get into that with somebody else, but this was just for completeness. I wanted you to have all of that on there. So our STEMI. So when you have a patient that has a STEMI, remember this was that full injury, that full thickness where they had that tissue being damaged. So with this, your goal is to quickly get them to the PCI. We're not really messing with the meds initially if I can get them to that PCI. Typically, if I am at a hospital, because every hospital does not have PCI capability, that's when you start to look at your medications and being like, okay, what meds can I give them until they can get to surgery if I can transfer them to surgery. If I can't transfer them to a hospital that has a PCI capability, then I use my fibrinolytics. Because remember how I told you in your NSTEMI patients or your regular unstable patients, we're not using fibrinolytics. In our STEMI patients, if I can't get the PCI, so my PCI is the procedure that I want to do. That is like gold standard. But if I don't have that capability at the hospital that I'm at, or I'm in some rural area where I don't have the capability to do that PCI procedure, then I'm going to use my fibrinolytics. And then this is a time-sensitive thing. So when you're looking at this, depending on the guidelines, they kind of change as you, and it may vary from time to time. So I want to walk you through this. So like your patient has their STEMI, you're going to go through and do what we call MONA-B. So your morphine, you'll give them oxygen, like you're just essentially trying to make them comfortable because they're going to be in pain. Nitroglycerin that we talked about, and give them that aspirin. Make sure that if it is not We typically will see where we tell people to chew the aspirin so that it can hurry up and like speed up their admin process, okay? So we'll say, hey, chew it. If you don't have a chewable aspirin, they can chew the regular one. It just tastes gross. But they're gonna be in so much pain, they're not gonna care. Chew this, okay? Which is typically what we end up doing. So this is just to keep them stable for the time being. Then you're seeing my symptoms are less than 12 hours. So this is kind of where we're going when we're looking at this. So if I have a PCI capable hospital, this is what I would prefer. This is like, yay, everything is working great. It's a great Monday, okay? So they're going through their PCI procedure. FMC is first medical contact. So this is the time that we're trying to say, like within 90 minutes of them having contact with a medical provider, that we want to treat that patient. I'm not gonna ask you all these times, I'm just going through this algorithm so you understand what it's saying. Now, you see where my meds are coming into play, right? So I did my PCI, I still need to now put this patient on some type of medication. They typically will end up on DAPT. They're gonna be on aspirin, they're gonna be on one of these meds, and sometimes we may have them on DAPT and they'll be on the GP2B3A inhibitor as well. Okay, so I can have them on 3 meds, I can have them on just 2 meds. It just depends on what's going on with the patient and how they're presenting to me at that time, okay? And then when I look at my non-PCI capable hospital, can I get them to the hospital within 120 minutes to get the procedure? If I can, then I'm not gonna give them that fibrinolytic. I'm gonna go down the same route because they're gonna get surgery. But if I can't, I keep them at that hospital and I'm like, okay, cool. I'm gonna give them a fibrinolytic to try to bust up that clot. Because your fibrinolytic is going to say, hey, where's that fibrin at? I need to get it. I wanna bust that up so that I can start to have some flow again. Because remember, I'm totally occluded. So it's gonna go through and it's gonna try to bust up that clot. What's the problem with that? The clot is now busted and all of that stuff is now floating around everywhere that was in that flap. Okay, so that's why we like PCI. Go in there, clean, get it, we're done. Okay, versus like, all right, now I have all of this stuff that I've made even worse whenever I'm using my fibrinolytic, but at least it's increasing blood flow. Okay, sometimes you'll see where they do this, and they'll follow it by a PCI if like they didn't get good reperfusion after they use that fibrinolytic. Okay, so you can see a PCI after you've given this. You see you have tenecteplase, retaplase, and alteplase. Depending on what institution you're at, they will have one that they prefer, and they will usually stick to that one. And then they still end up on medication, so they're usually also on DAPT. But you see the clopidogrel is the option that we like to use here, and then they're going to be put on an anticoagulant to try to help make sure that all of that plaque and that stuff that we busted up out of that plaque doesn't go and form a new thrombus somewhere. So they're on an anticoagulant for a little while afterwards as well, okay? So understand that this, when we're talking about a STEMI, they are in the hospital because they're gonna have more issues. Our in-STEMI patient in the hospital, okay? So any of those ACS events that we look at, they're usually in the hospital because we're gonna have to treat them. And then they get sent home with new drugs that they're gonna be on for some time. They usually won't stay on DAP for the rest of their life. They may be on aspirin for the rest of their life, but not necessarily both medications. Some people, you'll see them, like the cardiology will switch up how they're doing it. They'll stay on clopidogrel for a period of time as well, and then that might drop off. Or they'll say, hey, I don't want to risk it, you're going to stay on here, depending on what their TIMI score was, which is a different score that they use to see like the likelihood of them having issues. So very complex disease state that y'all are going to learn about. I just wanted you to see the different drugs that you had available when there is a PCI versus when there's not a PCI. This was that initial management that we were talking about. So your Mona B, remember if they were giving that aspirin, they're trying to chew it. If all you have is enteric-coated aspirin around, chew it, okay? It's not gonna work as well as we would like it because it has that coating on it. But when you chew it, it breaks up that extended release or enteric-coated Usually our enteric-coated aspirin is like an extended release form of aspirin, but if that's all you have, it's better than you not giving them anything at all, okay? So these are our different things that we'll use. So you see your morphine. Essentially, this is just helping us with some of the pain, and also we can get vasodilation from our morphine whenever we're using that. Oxygen, because they're going to be short of breath. Your nitroglycerin, we already talked about this, right? So it's going to help with some of that vasodilation, help you with the pain also. Our aspirin, we talked to you about chewing it. If they can't have aspirin, then we have the clopidogrel that we can use. But again, expect with these medications, even when we're talking about aspirin, a lot of GI issues come along with us when we're talking about these antiplatelet drugs. And then your beta blockers, we're using this. Remember, anytime we talk about our beta blocker, remember our mortality benefit that we're getting with our beta blocker. Same thing applies here as well. Okay. This is looking at our additional therapies that you may end up seeing added on for your patients once they've been hospitalized. So we have our ACE inhibitors, our aldosterone antagonists, statins that we talked about, your nitrates, and your calcium channel blockers. So same indications that we mentioned before are the ones that are listed here. Has your contraindications on there. So looking at things like your aldosterone antagonists, right? I need to make sure that I'm not making them more hyperkalemic. Like all the things that we've mentioned before, same thing is applying here. It's just a summary chart because these are the things that you're going to see when we're talking about ACS and trying to prevent those bigger events from happening, and like looking at a STEMI or in-STEMI, okay? What else do I want you to see from here? That's really the main things when we're looking at this. When we're talking about our statins, it says your high intensity statins, so make sure when we go over statins, you'll know what they are. Don't expect me to remember that now. Just know high intensity statins, okay, with your patients who can tolerate them. You are going to have some patients who cannot tolerate your high intensity statins, and we will have to put them on more of a medium dose of that statin. Remember our calcium channel blockers. What options did we have for our calcium channel blockers? What was our acronym? FAN. Okay? It's not every single calcium channel blocker, and then that's if you're using your DHP, or I can use my non-DHPs. Remember, I want to stay away from my immediate release also of my nifedipine, right? Because I can make everything be worse for them. So as you're going through this, just kind of remember your options that you have available to you. So at discharge, you've taken care of the patient while they were in the hospital, they were under your care, you did a great job, and you're like, now, here is your package to go home with. This is what I'm going to now discharge you with. You can see that this DAPT will last for 6 to 12 months sometimes, depending on the provider, depending on how bad that patient is, what's their family history, like getting that whole picture, right? So you can see 6 to 12 months of treatment, and then they'll usually do just one by itself. But here are our medications that we have. So my DAPT was me using my aspirin with my clopidogrel for up to the 12 months. I'm on a beta blocker now for 3 years. Regardless of if these patients feel better, this is what they should be taking to prevent them from having another ACS event, okay? This is guideline directed, so these are things that can always change as well. Also understand that some providers may say, I want to go longer in my patient, okay? So as long as they're at least getting these minimums, you're satisfied. Your ACE inhibitor, this is if your patients are going to have any of these comorbidities that are around that could be contributing to why they're having issues, right, and why they're having more fluid and things like that around. Your aldosterone antagonist, same things that we talked about already, and my statin is just helping with that coronary artery disease and trying to make sure that I have clean arteries so I don't have any speed bumps. I'm just able to flow, okay? Any questions so far? All right, we're just going to do the beginning of this next lecture, and then I'm going to just we'll be done. All right. So, heme. A lot of the drugs that I was just telling you about were going to be in more detail when we were looking at them here. It's going to go over making sure that we're keeping track of what is my fibrinolytic, what is my anticoagulant, what is my antiplatelet. So the name of this slide deck is remembering what category everything is going to fall into and trying to remember when you're using what, okay? Several different monitoring parameters that we're going to talk about also, so make sure that you're paying attention to that as well as we go through these. Okay, ELOs listed here. And then some terminology or background for us to look at. So when we think about a thrombocyte, we are typically saying platelet. Very few people walk around and say a thrombocyte, okay? So when we think about our platelets, they're typically not a problem. The problem typically occurs if there's damage to the endothelial lining, which then will release prostacyclin and nitric oxide, and then we start to have platelets get activated, and then they start to say, hey, everybody come over here. And then they start forming up, they gang, okay? Because they like put out their feelers, and then they're trying to say, okay, I need to make a plug somewhere. I need to fix something, right? Because something was damaged, that's what activated them, all right? So sometimes our body can overdo it. Okay, and then we start to have that thrombus that will form, which we'll talk about. So our thrombus is the clot that we form whenever we have damage to that endothelial lining. So I've activated those platelets, I activated the coagulation factors because I want to plug this rip. I'm trying to stop this from leaking. Okay, so think of it as it's trying to make a patch, trying to cover up whatever that cut was that happened there. And then when we look at thrombin, because we're going to have meds that are going to target these things, when we look at thrombin, this is formed from our prothrombin that is going to help facilitate how we're going to do clotting and different things like that. And then it's also going to make more fibrin, which could also be an issue. So these are going to be things that our drugs are going to target to make sure that we are not forming clots that are too big, okay? So when we think about our coagulation cascade, I want you to think about the platelets are being activated and they're trying to form a clot to stop or to fix that damage that happened in that lining, in that endothelial lining. Our three phases that we have of that thrombus formation is going to be adhesion, activation, and aggregation, okay? So I'm going to go through all of the different stages that we have, and then understanding that typically you should have, if somebody does not have a bleeding disorder, we should see that that clot is formed within 3 to 6 minutes. If it's taking longer than that, typically that means that somebody is either on some type of medication that is thinning their blood, or they have an issue with clotting factors as it is, and therefore they're bleeding for a longer period of time, and that clot, because that clot isn't forming, right? There's something wrong with their coagulation cascade, okay? This is just a picture of what we keep talking about whenever we're looking at different types of plaque and what we typically would expect our body to do if there is some type of damage. So here you have a normal cell, it's just minding its business. You have the nitric oxide and the prostacyclin being released to kind of manage everything that's going on. And then when you're looking at this homeostasis, you see that we have camp. Anytime you see camp, also just try to think about like, this is decreasing like the calcium, it's inhibiting that GP activation. Those things being activated is what is going to say like, okay, I'm going to start to, when they are activated, you're likely to see clots forming. I guess is the easier way to say that. So then looking here, you can have where there's something that could occur to where that plaque ruptures, right? So we had fat, we had calcium, we have fibrin, we have all of this stuff, TXA, all this stuff that was in that plaque that is now exposed into our body because it ruptures. So it's not stable anymore, And then that's what's causing more activation to occur, because now they're like, hey, we need help over here, okay? The platelet aggregation can occur. And then here, this is where you see now your CAMP is not being synthesized anymore, and then that's what starts to say, hey platelet, let's become activated. Again, recruitment, we need everybody to come over here, okay? So you see ADP, TX2, these are things that, again, will be targeted by our drugs, especially when we look at TXA2. You'll see this a lot. And you probably already seen it when we talked about like aspirin and things like that. You all have seen aspirin previously. I know not for me, but you've seen aspirin before. That's TXA2. And then looking at your aggregation, right? Everybody is coming, and so now we are doing the cross-link with our fibrin, which is why that's another target, and therefore we'll end up with a thrombus that ends up forming, okay? And then this becomes our problem. Sometimes we don't want a thrombus to occur, because it can occlude things. So when you look at our adhesion, the big thing here is that you're trying to say now, like, there was some type of damage that occurred in that epithelium or that endothelial cell, okay? And so your platelets are trying to say, hey, I need to plug this up. I need to stop this leak that I'm having right now, so I need to plug it up. And so you have your von Willebrand factor, or VWF, which mediates that platelet aggregation at the site of wherever that injury is, for it to form that plug that is going to form. You have different disease states to where sometimes people may be deficient in this, right? So remember how we were talking about if a person has any type of deficiency, they could potentially bleed longer. Because if I don't have my von Willebrand factor, this is a bigger component in how I'm going to be able to say, hey, let me plug this site up. Where is that site if I'm not secreting this protein? And then you see, once we have damaged that endothelium, you see the PG and your NO being released. And this is where you see like their different functions, right? So both of them cause vasodilation. This is trying to say, hey, I need platelets, but I don't need that many of you, so not like aggregation to the point to where it can form a thrombus, okay? And your undamaged cells that we have, you see that it's going to have that CAMP, which is why you don't have that platelet aggregation, which is going to come and form that thrombus, right? So I don't have all of those aggregating factors coming in, those mediators coming in and saying, hey, over here, in a normal healthy cell, because I have CAMP. Once I stop the formation of that CAMP, that's whenever the party is starting. That's whenever I start my recruitment. That's whenever I start to see the adhesion occurring, and that's when you're going to get the aggregation later, okay? So here, when I have my PG and my NO, I'm essentially keeping that vasodilation to where everything is moving smoothly, okay? So not any unnecessary clotting happening in that. When you look at your activation and your aggregation, okay, think about activation as what we've been talking about. There were some type of mediators that ended up getting released, and they're bringing everybody over. So your TXA, you have serotonin that could be in this. There's platelet aggregation factors. So all of those kind of mediate. They say, hey, everybody, come over here, okay? That's all I need you to know. This is just giving you more background into the things that are going to play, because when we talk about our drugs, we're going to talk about like where they're targeting these things specifically. And then your platelet aggregation, we have our TXA specifically, which is going to help with the vasoconstriction that we're going to see and help kind of form that plug that we see. And then your activation of glycoprotein, so your 2B, 3A receptors, which are going to deal with the fibrin, and we're going to see a lot of activation that occurs from that, which is why sometimes, depending on what drugs we're using, we're targeting this to try to block that from happening so we don't get that thrombus, okay? So this is essentially showing you have prothrombin, which then gets converted to thrombin, which converts your fibrinogen to fibrin, which is what ultimately will make your clot, okay? So this is just trying to let you know how does it typically happen, And then when I give my drugs are going to target certain things in this cascade to say, no, I don't want that to happen, okay? This is just showing you the picture of us. We've been using TXA and talking about TXA and talking about your PG or our prostaglandin here. So looking at this, our TXA, I mentioned to you already that we were dealing with some vasoconstriction when we were looking at that. And then when we had our PG, especially in our normal healthy cells, we had our vasodilation that was happening. So think about this as your COX pathway or your platelet activation is starting in the process of or in the presence of our prostaglandins. And then when we look at certain medications that are like our irreversible COX inhibitors, right? We stop that from happening right here, and therefore I don't have any of this down effect. Okay, I don't get those pops that I'm expecting to see. Okay, these are our two different pathways that we have, our intrinsic and our extrinsic, which lead to us forming that clot. Okay, so when our platelet activation starts, we have these two different ways that we're going to look at. I don't specifically need you to remember this. I would prefer that you remember the words. Specifically when we talk about Coumadin, you'll see when we're looking at specific factors. So like we'll look at 2, 7, 9, and 10. So like I want you to remember it that way. If you want to remember all this now, you can, totally up to you, but I don't need you to remember it this way. I'm going to talk to you about it in a more word way instead of trying to remember every single factor, because we don't deal with every single factor. So when you're looking at your intrinsic pathway, we'll talk about our heparin and how a lot of them will target this intrinsic pathway, so different factors that are dealing here. And then when we're looking at our extrinsic pathway, which is some of these things that are going to be here and down, we'll talk about warfarin and several different other medications that kind of are going to deal with this. So our thing here is that we're trying to prevent it from getting here, which is what is going to help form that clot. We're trying to stop it, whether it be here, like there's several different chances that I have to stop the formation of fibrin, which is going to cause my thrombus formation, okay? So I can target several different factors along the way. So this is what our platelet looks like whenever it was resting, and then this was like, hey, aggregate, come over here, activated platelet looks like. And this is what we're trying to prevent. We're trying to prevent this, and I think about it as it's being more sticky, like it has more arms out, more fillers out, and so now I'm going to get stuck on there and I'm going to form that bigger thrombus. All right, depending on what medication we use, we have different monitoring. Some medications require monitoring, some of them do not require any monitoring, okay? So it very much so depends on which drug you're using, if you need to monitor or not. A big one that we talk about is going to be our Coumadin or warfarin, and we have entire clinics that will monitor that for you. So if you have a patient that ends up on warfarin, they're usually going to be going to a warfarin clinic or a Coumadin clinic where they're specifically pulling those labs for them and monitoring them. If you have a patient that comes into the hospital with, and they're on one of these meds, you need to get a level and make sure that things that you are now manipulating while they're in the hospital, one, doesn't interact with the medication that they're on, and two, that they're still within that therapeutic range, which can change depending on what the indication is for their warfarin that they're on. So your prothrombin time, this is essentially like looking at your extrinsic pathway, trying to see like how long does it take for the clot to form, and they have different targets, again, depending on what condition you're treating with that medication for, okay? So these can vary, like it may say 2 to 3 for one condition, like we'll look at it. I don't need you to remember INR targets and different targets. You will be able to look that up. Okay, I just want you to know if a drug has monitoring or if it doesn't have monitoring, and if it has monitoring, what type of monitoring it has, okay? So when you're looking at your INR, this is typically what we're talking about. This is typically what we monitor for our patients who are on Coumadin. Coumadin is one of our older drugs, but it's one of the ones that some patients, when they're on it and they're managed with it, they're like, leave me alone, I'm staying right here. I don't want to be put on some of your newer meds that we have, and we'll talk about our DOACs, which don't have monitoring that we have to do. But some of your patients are going to be older, or there are certain reasons why they can't take a DOAC to where they'll still be on Coumadin, and we'll have to send them to one of those Coumadin clinics. So when you look at a low INR, essentially what that means is that they have quick clotting, right? They're not bleeding for that long, versus if you look at a higher INR, they have slower clotting, okay? So that means that they're gonna be bleeding for a longer period of time, which is not fantastic. So if you overdose the medication, or overdose a patient on one of our anticoagulants, they're gonna bleed for a longer period of time, which is not great. Our anti-factor 10A, this is looking at anticoagulant activity that we have of our medications that are going to target 10A, so we'll look at those, and this is kind of going back and forth on if it's required monitoring or not. Most of the time we don't measure anti-factor 10A. More expensive, takes more time. And then your activated partial thromboplastin time, or your APTT, is another test that we have, and this is more so looking at our intrinsic factors and how they affect the clotting. Pathophys, understand that there are bleeding conditions. If there is something that is wrong with our naturally inherent protein C or S, which are our natural anticoagulants that we have, if somebody has issues with that, they're going to have a bleeding disorder, okay? They're going to bleed for, they could have issues where they're not forming clots very well. So therefore their blood is going to be kind of, well, I shouldn't say it, they will have thicker blood, okay? Because they're not having that natural anticoagulant that's kind of thinning their blood out to a normal way like you and I might have. And then you see what happens when we don't want clot formation that occurs. You'll see DVTs that can occur. So deep vein thrombosis, you can end up with different types of emboli. We'll talk about those, a VTE versus a PE, and then we have different treatments depending on where that clot has occurred. So this is a clot that's going to be in your blood, and then this one is your pulmonary, and your stroke is essentially it happened in your brain, cut off the blood flow, and then they have a stroke or ischemic stroke. This is your Virchow's triad. You'll go over this. Just understand that sometimes there are different disease states that can occur, and when we look at this, that they can contribute to the patient forming a clot. So these are things that can increase thrombosis. So there's essentially three different categories. You have hypercoagulability, hyperdynamic or hemodynamic changes, and then you have endothelial injury or dysfunction. These can change as well if somebody is pregnant, right? Because those patients are usually hypercoagulable. And we don't typically think about that, but remember that this is a thing that can also happen in those patients, okay? So when we start tomorrow, we're going to start with our meds, and we'll go through this. It's going to take us a couple of days with this, maybe. All right, have a good day.